All right. Welcome, everyone. Thank you so much for joining us. Joyce, I'm just going to allow a few more seconds for our participants to join. Thank you so much for joining. Okay, let's get started. Well, welcome everyone to our webinar today on the effects of syndemics on public housing residents and other medically underserved populations, the interconnectedness of disease. This webinar is provided to you by the National Center for Health in Public Housing. This is just a kind reminder to everyone that all participants are muted upon entry. Please make sure that you also engage in the chat if you have any questions. If you would like to also participate or have any comments or any promising practices that you would like to share with us regarding today's topic in the chat, please make sure you also raise your hand if you would like your line to be unmuted during our Q&A session or also during our case study section. This meeting is also being recorded. The slides and recorded link will be sent via email after today's session. And please, as always, let us know about you. So please provide your name in the chat, your state, the organization that you represent, and your title, and also what brings you here today. So with us today, we have our wonderful speaker. His name is Dr. Jose Leon. He is the Chief Medical Officer at the National Center for Health and Public Housing. And he also serves as the Chief Health Officer at La Maestra Community Health Centers, where he leads community health strategy and implementation of the Circle of Care model to address medical, behavioral, and social needs in San Diego communities. As the Chief Medical Officer at NCHPH, he has over 12 years of experience in developing TTA assistance programs for community health centers serving public housing populations. He's also a national leader in population health and chronic disease prevention, contributing to major initiatives such as the American Diabetes Association's Practice Committee and the development of the standards of care in diabetes. And this is just a brief introduction about ourselves. My name is Fide Pineda Sandoval. I am the TTA manager here at NCHPH, and I will be co-moderating with my colleague, Olajumoke Oladipo. She is our health communications and research analyst and is also in the line with us, helping with our logistics. So for today's learning objectives, we'll be focusing on defining and explaining the concept of syndemics, identifying key co-occurring conditions and upstream drivers of health, and also how to apply syndemic-informed strategies to care planning. Now, without further ado, I'll pass it on to Dr. Jose Leon to get us started with the webinar presentation.
Thank you, Fide, and hello, everyone. It seems that we have a small group today, so if you could type your name, as Fide said, and your title and the organization that you represent in the chat so we can know each other and see how we can have an interactive session today. Today, we are going to have a conversation on a topic that all of you are very aware of because you somehow address all these issues in the populations that you serve. However, from a clinical perspective, is a little bit complex because we are going to talk about syndemics and HIV. For those who are not familiar with the concept of syndemic, syndemic is an abbreviation of a synergistic epidemic or synergistic epidemics. and is when two or more conditions interact each other, and then either of the conditions exacerbates due to the presence of a second or a third condition. This is really interesting because in addition to all the pathophysiology and the interaction of these conditions, there are non-clinical needs or social determinants of health that also are affecting the relation between these conditions. And then this can be another issue or another piece that is going to make uh, the conditions worse. So what is going to happen is that in patients with HIV, in addition to all the inflammation that we have produced by the condition, by the disease, we have other infectious diseases and non-communicable diseases that are going to be affecting our patients, depending on the background of our patient, depending on how the patient it takes care of himself or herself. If the patient is obese, but the patient is also going to have diabetes, and as you know, in health center settings, diabetes is a big concern. Or if the patient develops hypertension, then we are going to deal with other comorbidities in addition to all the treatment that we are going to provide to our patients. So it's really interesting to see this interaction and how one condition can worsen the other one or can exacerbate one of the HIV or the other condition. Next slide, please. This topic is really relevant for community health centers in general because we are going to talk about non-clinical factors. By non-clinical factors, we are going to have a conversation about housing instability, about access to care, either the patient experience homelessness, or if the patient has difficulties accessing healthy food. So all these clinical factors, in addition to any chronic medical condition, in addition to any infection condition, are going to magnify, are going to increase the likelihood of having signs and symptoms of HIV or other conditions that are going to be affected by these non-clinical factors. Also, we have the interaction of other infectious diseases, and specifically we are going to focus on STIs, on sexually transmitted infections, because these conditions occur more frequently in patients with HIV. So when we're having a patient, we need to keep a patient with HIV or patient who is at risk of developing HIV or getting HIV. We need to make sure that we address all these issues. We have to address either if the patient is an HIV patient, we need to make sure that we focus on non-infectious diseases, on communicable diseases, on the clinical factors or non-clinical factors affecting our patients. And in addition to that, making sure that the treatment that we are providing is the treatment that the patient is going to need based on the needs of our patients and any non-clinical factor affecting our patients. Next slide, please. We're going to get started with sexually transmitted infections among people with HIV. As you know, according to research and literature review on some report from the Centers for Disease Control in the United States, or WHO that also provides international data, we know that syphilis, chlamydia, and human papillomavirus is more, or these three conditions are more frequent in patients who are at risk of HIV or who have developed HIV. So the first thing that we have to, or that we need to keep in mind is the interaction of these conditions and making sure that we also address any sign or symptom of these condition of these STIs when we're having conversation with our HIV patients. Next slide, please. We know that there are other malignancies due to inflammation. As we know, there are some cancers that are AIDS related, and we know about the Kaposi's sarcoma. We know about non-Hodgkin lymphomas. We know that patients with HIV or specific women with HIV are more likely to have cervical cancer. There are other non-AIDS defining cancers that also we need to keep in mind, specifically depending on the risk factors of our patients. We can mention liver cancer, lung cancer, and oropharyngeal cancers. So all these are really important. It's not that because the patient is an HIV patient, the patient will have these cancers. It's because of the other factors that we mentioned. If the patient, a patient can develop a liver cancer if the patient is Hep C positive, if the patient has an hepatitis C infection in the long run and without treatment, the patient will develop or can develop liver cancer. Lung cancer, we need to make sure that we address the any smoking history in our patients, making sure that we understand whether or not the patient, due to several issues, either social issues or mental issues, is a chronic smoker. We need to address that, as well as the oropharyngeal cancers, the oropharyngeal cancer that is also linked to smoking or HPV. So we need to also keep in mind that these conditions can interact, and the interaction can worsen either the HIV condition or the other morbidities. Next slide, please. In regards to chronic diseases, we know first we are moving from communicable diseases to non-communicable diseases. We know that our patients are going now that our patients with HIV are living longer, and our patients can also develop other chronic diseases that are not linked to HIV, but the patients, due to the social history or the background or of our patients or the family history, can develop some conditions like hypertension, any cardiovascular disease, any chronic kidney conditions. And also, if our patient is a smoker, we can have, we need to make sure that we also address COPD, just to make sure that we have the big picture of our patients. Next slide, please. The next thing that we are going to discuss are the non-clinical related needs. Next slide, please. And patient and how the non-clinical related needs affect the syndemics in our patients. So let's take a moment to think about what you see in your health center settings every day, and everything that you have to address in addition to any or to the reason why the patient is coming to the health center. So in the intake process, we need to make sure that we address anything that is related to housing, to nutrition, access to healthy food, and all these, whether or not the patient has insurance or is underinsured. And in addition to that, we need to make sure that we have a the mental health history, whether or not the patient is misusing any substance, whether or not the patient is having depression or anxiety or any other mental condition, whether or not there are other risky behaviors in our patients that can take them to either develop a non-communicable disease or contract a communicable disease. Also, we need to make sure that we also address the other STIs as we discussed and any intimate partner violence that sometimes is common in our patients with HIV. Next slide, please. On this slide, we see the interaction between anything that is biological, social, or structural, and behavioral. So this is an idea of what we need to keep in mind when we are going to have a conversation with a patient, making sure that there are no other interactions or there are no other conditions interacting with the condition that we are going to treat. And this concept applies for any condition. It doesn't apply just to HIV, but any time that we have an encounter with a patient, we need to think about the biological aspect, the condition that the patient is being affected by. We need to think about how this condition is affecting their mental health, or if there is any other social issue that is also affecting either the mental health of our patients or is exacerbating the condition that why the patient is coming to the clinic. Next slide, please. One of the conditions when we started seeing patients with HIV, one of the main concerns was the interaction between tuberculosis and HIV, because in the very beginning we had patients with HIV who develop tuberculosis or TB. So the synergism between these two conditions are that HIV, an HIV positive patient can have a reactivation of latent tuberculosis or just acquire active tuberculosis. And we know that if the patient has the CD4 lymphocyte T um, low, that can increase the risk of TB, and specifically in non-infected person, as I mentioned, and is not going from latent tuberculosis to active tuberculosis. But if a patient gets in contact and if with someone with TB or is in contact with the pathogen, the patient can go from being asymptomatic to develop TB symptoms. And we know that these patients, because in the very beginning they were very immunocompromised, our patient could also develop extrapulmonary tuberculosis. And what we know is that even if the patient had in the past HIV didn't have any impact on the TB treatment, so the patient responded well to tuberculosis treatment. Also, we need to make sure that if we have a patient who is not a U.S. Resident or a U.S. citizen, and this person is coming from another country where TB is prevalent or the incidence of tuberculosis is higher than here in the United States, then we need to make sure that these patients also receive the appropriate test to make sure that this patient doesn't have either latent tuberculosis or active tuberculosis. Now, in regards to interventions, and specifically for those patients with HIV and TB, we need to make sure that we address both conditions. We need this integrated care. How can we do that? Well, first, we need to test our patients, making sure that there is no latent tuberculosis. If the patient has a positive test, then then we need to make sure that the patient receives treatment for latent tuberculosis. If the patient has active tuberculosis, making sure that we first, since this is a communicable disease, we need to report this to our state health department or local health department. and then start treatment. We need to make sure that the patient has both the ART treatment as well as the latent tuberculosis treatment, and making sure that we also get in contact with any relative or any close contact of our patients to make sure that we also test our patient, these people, or test our patient for latent tuberculosis. Next slide, please. Syphilis is another condition that is linked to HIV, and we need that because this is a STI. Patients with syphilis are more risk of HIV, of acquiring HIV. So anytime that we have a patient, and if the patient has the signs or symptoms or test positive for syphilis, and the patient has never received an HIV test, we need to make sure that we address both. We test for not only for syphilis and HIV, but for other STIs. We also know that syphilis is a condition that can increase the progression of HIV. And this progression, when there is a decrease in the CD4 T lymphocytes, we can have tertiary syphilis or neurosyphilis and some atypical presentations. And in patients with HIV and syphilis, we know that is really important to make sure that we address, and we test for patients. And the CD4 is important to make sure that there is no decrease in the numbers of lymphocytes. So what interventions can we use if we have a patient with syphilis and HIV? As we said, we need to screen for syphilis in our patients who are at risk, and provide STI services, integrated STI services, to make sure that we are helping our patients with any of these conditions that can also exacerbate HIV. Next slide, please. In regards to the other STIs, and here we can talk about gonorrhea, we can talk about chancroid and everything else. There is, remember that all these conditions can or produce an inflammation, and the inflammation can weaken the tissues, and this is a risk of HIV acquisition. Also, STIs can increase the HIV replication, and that's going to affect how the patient is responding to a treatment if the patient is receiving treatment. We also we know that HIV, on the other hand, can also increase risk for other conditions. We know that the most common STI in the United States is HPV. And then we also need to make sure that we are addressing any of these conditions and making sure that we have this conversation with our patients, looking for signs, looking for symptoms, or testing our patients. And in regards to interventions for these patients, again, integrated services for STI and HIV, and WHO recommends syndromic STI treatment. And syndromic STI treatment is when you have a patient who is at risk, and the patient, you don't know if the patient is coming back to the clinic. Let's say that you have a patient experiencing homelessness, and the patient has HIV, is receiving treatment, but you see this patient for another condition, another STI, and the patient refers to have a discharge, for instance, or and has any or pain when the patient urinates. We need to make sure that if we even if we test the patient before we wait for the results, we need treat the patient based on the signs and symptoms, and then we can confirm the disease when we have the lab results back. This is a recommendation from WHO. Generally, is for populations that we don't know whether we are going to see them again, whether the patients are coming back, or in other third world countries, is this is something that is that also is in place to make sure that where the patients are receiving the treatment that they need. Next slide, please. Another condition that is a syndemic or a co-infection with patients with HIV is hepatitis C. We know that HIV can accelerate the rate of fibrosis, and that can damage the liver, and the patient can also develop some liver cancer. So if we have a patient who tests positive for Hep C, who is an HIV positive patient, then we need to make sure that the patient receives the integrated services that we have in our clinics. If you don't have the ability or the expertise to treat these patients, we need to refer patients to um, someone like infectious disease doctor or someone who is more familiar with Hep C, and making sure that the patient receive the treatments that they need. And in addition to that, we can also use some of the strategies that we have for patients um, with infectious diseases, just to make sure that there is no we prevent a reinfection. But this is something that is really important when we have patients with HIV, making sure that we test them for Hep C, Hep B, Hep C, for other STIs. And then if the patient, since we know about the synergistic impact, on HIV and Hep C, is also always recommended to make sure that the patient receive the treatment for Hep C, as well as any additional tool that we can have to make sure that there is no fibrosis or the risk of of liver cancer. Next slide, please. If we move now to the mental health part of it, we have seen the interaction of HIV and some STIs. Now we are going to see the mental health aspect. We know that we have an epidemic of substance misuse in the United States, and the issue with patients with HIV is that because of all the social background that the patients can be affected by, and whether the patient is stigmatized or whether the patient is um, uh, if the patient has any type of intimate partner violence, that can cause the use or misuse of some of of substances. So we need to make sure that we provide different interventions like medications for opioid use disorders, the screening brief interventions, any contingency management. We need to make sure that we refer our patients to our substance misuse specialists. Many clinics, health centers have psychiatrists addressing these issues in our patients, and CBT is also recommended, making sure that we go, have this conversation to our patients so our patients can identify the issue, why the patient is using these substances, if there is any information that we can get and then modify based on what the patient has found. Next slide, please. We know about the psychiatric interventions as well. We discuss depression, anxiety, and other mood disorders, making sure that we screen our patients for depression and making sure that the patients receive again CBT. And literature also recommends the use of effective skills to empower effective men. And this is related to once the patient understands what is behind, what is the reason, or can identify the reason why the patient is either misusing drugs or if the patient is suffering anxiety or suffering depression, the patient can make a change, and at the same time, the patient can have a positive uh, uh, response to any of these issues that are affecting the patient. And sometimes it's quite difficult for the patient to identify what the issue is, but at the same time, once the patient has identified the issue, the patient needs to change that behavior and making sure that they have a positive response to any of these conditions, like the misuse of some substances, or if the patient has anxiety and depression, in addition to the treatment that the patient need for these conditions. Next slide, please. We mentioned intimate partner violence. We need to make sure that we screen for violence in our patients, specifically in our female patients. Remember that any violence, in addition to any of these infectious diseases, are going to increase the presence of depression and the presence of anxiety. And all these uh, interactions can also cause uh, instability, specifically socioeconomic instability. Patients can also lose their employment, and patients can go homeless. So we need to screen for any type of violence and making sure that we address the behavioral aspect. As we know, the interventions are similar. We have talked about CBT interventions. We have talked about the use of web-based and remote interventions that is extremely useful, making sure that we address any social determinants of health and any housing instability for our patients who are suffering intimate partner violence. Next slide, please. For patients who are incarcerated, we know that there is an impact on these patients that they are more likely to have any or other infectious conditions. TB is one of them. As I mentioned, that patients with HIV in these settings can also develop tuberculosis and other type of STIs in addition to Hep B or Hep C. Also, these patients are more likely to use or misuse drugs, and these patients have depression and anxiety. There are some interventions for these patients, and specifically when they are released from prison, some health centers have some programs specifically for this population. And the idea here is to make sure that they have continuity of care and identifying any other issues that or any other conditions that the patient can be affected by, and making sure that we also address any trauma and anything else that is affecting this population. Next slide, please. Here at the National Center for Health in Public Housing, We focus a lot on housing instability and interventions. We know that there are several programs like public housing or vouchers that can be used when the patient is showing a housing instability or is saying that they don't have where to live, or patients are experiencing homelessness. So this is an issue that we need to make sure that we address, and at the same time making sure that these patients are more likely to have other conditions in public housing. For instance, 33% of patients with diabetes have uncontrolled diabetes. Many of them have more than one disability. The use of or misuse of substances is more frequent in patients experiencing housing instability. So all these are the issues that we need to make sure that we address when we have in a patient with HIV, or coming from, or who was incarcerated and is coming to either how is going to be a housing voucher recipient, or he's going to live in public housing. Next slide, please. So what are the key points? We need to make sure that these conditions are affecting our patients and they are going from one to the other one and vice versa. In other words, if we have a patient with HIV and this patient develops TB, the TB can affect how the patient is responding to the HIV treatment, and at the same time, HIV can also affect any TB issues in our patients. Either if the patient has latent tuberculosis, the patient can develop active tuberculosis or can go to active tuberculosis. So let's make sure that we also address all these issues. And as we mentioned, we need to make sure that we see the previous diagram where we saw the biological piece, the structural piece, and the other section that was the behavioral issues. If we make sure, if we address the three buckets, then we'll be addressing syndemics in a patient with HIV and helping them with all their healthcare needs. Next slide, please. So we have a case study, and I hope that we can have your participation. We have two case studies for today's presentation to make sure that we have um, um, everything that we need to respond to syndemics in primary care. So you can either use this chat box, or if you want, you can also raise your hand and your line can be unmuted. So our first case study is about a patient, a 32-year-old patient, a Latino patient, Antonio, who's been living with HIV for the past 6 years. He's lived in the United States for 17 years, although all of his family still lives in Guatemala. When he shows up for treatment, his healthcare provider realizes that Antonio has not been adhering to his HIV treatment and that his viral load is increasing. Antonio tells the healthcare provider that he has had severe diarrhea ever since return from visiting his family in Guatemala, and his condition prompted him to seek treatment. He informs the healthcare provider that he's been praying several times a day and receiving the spiritual cleansings from a folk healer who lives nearby. However, he doesn't seem to be feeling any better. When the health provider asks why Antonio has not been adhering to his treatment regimen, he responds that he is afraid of the harmful side effects that the drugs may have on his body. Next slide, please. So we have a few questions here. Our first question is, what are the interacting conditions affecting Antonio? So we can go over the whole case. We don't have to go one by one and respond one by one because it's going to take time. But if you see the question is, what is interacting? What common syndemic contributors do you see? Is Antonio increased is at increased risk for an opportunistic infection? What additional screening is needed? How could Antonio be affected by living in isolation from his family members? And could this have a negative impact on his adherence to the treatment regimen? So take, we are going to provide you with a few seconds so you can see the case study questions and use the chat box and respond to any of these questions and see how we can help Antonio if we understand what is affecting Antonio, who's been in the United States, who got a gastrointestinal condition or infection, and what we can do to help our patient. So please, if you can use the again the chat box, or if you would like to interact verbally with us, let us know, and your line can be unmuted. Okay, we can go one by one. Here, and the first question is, what interacting conditions are affecting Antonio? We know that we have a patient who's been diagnosed with HIV, and the patient has another opportunistic infection. So that is the interactive condition. Because the patient has not been adhering to his treatment, the patient who was visiting some family members in Guatemala developed an intestinal infection. At this moment, we need to make sure that we address the condition or the infectious disease, the co-occurring infectious disease affecting our patient. We need to make sure that we see whether this is produced by an E. coli infection, for instance, that is common in Latin America, where the patient has a norovirus infection. So we need to make sure that first we address that condition, and then we are going to understand what is happening. Now, what common syndemic contributors do you see? What is happening here? So we know that patients who are HIV who by any reason stop taking their medication, they are going to have a low CDC count. I'm sorry, CD4 count, and the CD4 count, and that is going to be the trigger for an opportunistic infection. In this case, as we mentioned, the patient has developed diarrhea, and can be any conditions. Now, since we know that this is a patient who has traveled internationally, we need to understand what is happening, where this patient or where the patient was, and what they are the most common infections. So intestinal parasites can also be a contributor here. So all these we need to make sure that we have in mind in order to help Antonio. Now, as we said, he is at risk for an opportunistic infection. In fact, the patient has an active infection because the patient hasn't been taking his treatment. And now go to any additional screening. We need to see whether this is an infection caused by a bacteria or by a virus or by a parasite. So we need to do all that screening. As we know, his family is abroad, so Antonio has can also show some signs or symptoms of depression or anxiety. So we need to make sure that we screen our patient for any of these conditions, and whether or not there was a negative impact on his adherence to treatment. Um, of course, the patient has some religious beliefs. He also believes that the patient through other non-medical treatment can also get better. So all these can affect his adherence to treatment. So once we have these ideas, once we have this diagnosis, and we have already screened our patients for any non-clinical need as well as any behavioral issue, yeah, we need to help our patients, refer them to the appropriate resources that we have, treat the current infection, and screen also for any substance use disorder. Even though the history or the clinical history is not mentioning anything about the use of or misuse of any of these drugs, then as a healthcare professionals, we need to make sure that we also ask these questions to our patients. Next slide, please. Another case study, and now that you have seen the dynamics, I hope that you can also help us with this case. But we have a second case study. Michael is a 42-year-old Hispanic man who was diagnosed with HIV 3 years ago, and now he presents to the clinic for evaluation of persistent fatigue, unintentional weight loss, and recurrent upper respiratory infections. His medical history is significant for major depressive disorders and alcohol misuse, which he reports using as a coping mechanism for stress and depression. Michael is currently unemployed, experiencing housing instability, and doesn't have health insurance. Next slide, please. So what would be the integrated plan to help Michael? What interacting conditions are affecting Michael, and what common syndemic contributors do you see? Those are the three questions for this case study. If we can go back to the case study so our audience can read them or can read the slide. Okay, getting him insurance and addressing his mental health. Okay, can we go back to the questions? Okay, let's do an exercise. Based on what we have seen for our patients, let's start by what interacting conditions are affecting Michael. And remember that we mentioned that when we have the word syndemic, we are not just thinking about two co-occurring infections. We are not talking about a patient with HIV who has also developed another STI or TB or Hep B or Hep C. We're talking about how a patient with HIV can have other conditions. In this case, our patient is referring weight loss and is referring other symptoms that probably are not related to any infection. He's referring some issues, lung issues, problems. So here we need to make sure that also there is history of depression. So how all these conditions are interacting and exacerbating the symptoms that the patient is presenting. So we need to get information about whether or not our patient is a current smoker, whether or not the patient has history of any other STIs. If the patient has not been tested for other STIs, we need to test our patient for other STIs. We need to make sure that we also test our patient for Hep C or any other uh, uh, condition that can also produce any type of cancer. We talk about liver cancer. We have a conversation about that these patients are likely or more likely to develop either non-Hodgkin or Hodgkin lymphomas. So all these are going to be the conditions that might be interacting. And what would be the integrated plan to help Michael? Well, we mentioned already, we need to test our patient for other STIs. We need to screen um, for any non-medical needs. We need to make sure that we see whether or not there are some contributors that we can see. We know that with the patient has anxiety or depression. So everything, this is a complex case, and that we need to make sure that we have the time to first discuss with our patient the diseases that are being affecting our patient. Also, we need to make sure that we refer our patients to the services or patient to the services that we provide. But the first need is to make sure that we understand why our patient is losing weight and what is the origin of the lung issues that are affecting our patient. So once we address that, we can help our patients with the other contributors and the other issues that might be affecting the patient. If remember the patient has depression, we can start treating the patient for depression or refer our patient to the mental health services that we have in the clinic. So those are the main issues that we need to address when we know the concept of syndemics and how other conditions can exacerbate HIV or how HIV can exacerbate other conditions. Next slide, please. So at this moment, I'm going to stop and ask our audience if they have any questions. And I will pass it back to you, Phil.
Mm-hmm. Thank you so much, Dr. Leon. That was a wonderful presentation. So now is the time if you would like to have any questions for Dr. Leon or any advice you would like to obtain from him for the population that you currently serve. Please make sure you put it in the chat or in the Q&A session. Okay, so it looks like we don't have any questions so far. Well, in the meantime, while we have anybody that may be still be thinking about a question, I would like to remind everybody to please complete our post evaluation. Let us know how we did. Again, also please let us know your thoughts. Your feedback is always very important to us. And here is our direct contact information. If you would like to also follow up on any questions you may have about today's topic. You may also reach out to us directly to our email, which is provided here. And that should be it for today. So thanks, everybody. Have a wonderful rest of your day, and we look forward to seeing you all soon. And this is our disclaimer again. The information of today only represents our views. It does not necessarily represent the official views of the U.S. government. And thanks, everyone. Have a wonderful rest of your day.
Thank you, everyone.
Bye-bye.